Assalamu alaikum candidates. Now today we are going to discuss on the uterovaginal prolapse. What is uterovaginal prolapse? The descent of pelvic organ beyond its normal anatomical confines. So normally the uterus and the vagina, they both are inside the vagina, inside and not outside the vagina. So if the uterus and the cervix they come out, then it is going to be the uterovaginal prolapse. So because of the failure of supporting structures, it may be pelvic organ prolapse, it can be urogenital, it can be genital, or if there's rectal prolapse and rectocele, bladder then cystocele, or if urethra then urethro-cystocele, or there can be vaginal ward prolapse and after hysterectomy, or there can be uterine descent. Now, the anatomy of the pelvic floor is comprised of the pelvic floor, including musculature and the facial structures. Now, support of the abdominal pelvic cavity and external openings, they all are the support, and also they make openings for the vagina, urethra, and the rectum. Now, uterus and the vagina, they are suspended from the pelvic side walls, and these supports are divided into different levels, that is level 1, level 2, and level 3. Now, what is level 1 support? It is actually the upper third of the vagina, which is by the cardinal ligament and the uterosacral ligament. And secondly, it is if there is failure of it, then it can cause the vaginal vault or the uterine prolapse. Now, what is the level 2 support? It is actually the support of the middle third of the vagina. It is by means of, it supports the middle portion of vagina to arcus tendineus and fascia of the levator ani muscles, and if it is affected, then it is going to cause the descent of the bladder and descent of the rectum. And level 3 support is actually for the lower third of the vagina and pelvic diaphragm and the perineal membrane. These are included in it, and if there is weakness of it, then there is going to be vaginal vault or uterine prolapse, or there can be descent of the bladder, there can be descent of the rectum, or deficient perineum. So these were the three levels of support. Now what are the types of prolapse? First is the anterior vaginal wall prolapse. Now the anterior vaginal wall prolapse includes either there is descent of the bladder in cystocele, or there is descent of the urethra in urethrocoele, or there is descent of urethra and bladder, that is cystourethrocoele. Now, in case of the posterior wall prolapse, there can be descent of the rectum, that is rectocele, or there can be descent of the intestine, that is enterocele. And what is uterine prolapse? That is descent of the cervix and the uterine body into the vagina. And as I have discussed with you about the levels of the sport, that is level 1, 2, and 3, which are actually uh, giving support to the vagina. So now first, it is first degree prolapse, in which there is descent of the cervix into the vagina, but it is not as far as the introitus. So it is at now it is beyond introitus. In second degree it is at the introitus, and then coming towards the third degree, the cervix and the body of the uterus, they lie outside the procesdentia. So ultimately in first degree, before introitus, at the introitus, and then after beyond the introitus. So it can also be called as procesdentia. Procesdentia means there is complete eversion of the uterus. The uterus is whole outside down. And the vault prolapse, that is eversion of the vault of the vagina. And how does it happen? Definitely it happens after the hysterectomy. So now classification of prolapse, you have to remember that for classification of prolapse there are different classifications. These are the POPQ classification is actually the standard quantification method, where we have defined the and all the degrees of the prolapse, and generally they can be Beecham classification, Shaw's classification. So you can see that here there can be anterior vaginal wall prolapse, posterior wall prolapse, or uterine descent. So you have to see that whenever there is descent of the uterus, it takes the vaginal walls along with it, either anteriorly or posteriorly. So ultimately, anteriorly vaginal wall can be descent or posterior vaginal wall can be descent, and along with it, the uterus is also displaced from the normal anatomical confines. And etiology is that normally it can be because of some congenital defect, like if there is some collagen disorder, collagen metabolism, and ultimately there is defective collagen synthesis, so it can result in the prolapse. And repeated childbirths, like multiparous women undergoing delivery, repeated vaginal deliveries, and there is prolonged second stage of the labor, or we intervene by instrument and there is large birth weight of the baby. And also when there is some disruption of the normal pelvic floor, or there is possible denervation, and these all are seen in case of the prolonged second stage of labor, when there is damage to the perineum. It is menopause. Why? Because there is loss of estrogen, and ultimately collagenous tissue is deteriorated, and ultimately withdrawal of estrogen leads to a lack of support of the tissues and also the connective tissue. It can be iatrogenic, like in case of the hysterectomy. We do the division of uterosacral ligament. We don't go for plication of the uterosacral ligament on the vault of vagina, and ultimately results in vaginal vault prolapse. And also in medical conditions like obesity, cough, smoking, respiratory diseases, heavy lifting, constipation, or increased intra-abdominal pressure, as in case of some mass abdomen. So these are the possible causes of the uterovaginal prolapse. So you have to remember the causes, the classification, the support, and the clinical assessment. Now, a patient might be asymptomatic, or she might be having some dragging sensation in the pelvis, because some there is a prolapse of the uterus, so there is dragging sensation, like and patient is complaining of something which is coming out through the vagina. And ultimately what happens, that there is swelling, and ultimately why? Because the vagina, the uterus or the cervix, along with the vaginal walls, is outside the vagina, and there is increased pressure, and ultimately there is congestion and hyperemia, and overall there is swelling felt at the vagina. And if there is anterior vaginal wall prolapse, there are urinary symptoms. Patient might be having leakage of the urine with increased intra-abdominal pressure, like coughing or sneezing, or there is incomplete bladder emptying, because patient has to manually reduce the prolapse, and then she easily passes the urine. So ultimately, this leads to repeated urinary tract infections, and also it can manifest as frequency or nocturia, urgency, or cystitis, that is also inflammation of the bladder. Now, these all are actually the symptoms felt in anterior vaginal wall prolapse. Now, as far as the posterior wall prolapse is concerned, so definitely the patient experiences there is difficulty in defecation. So she has to manually reduce the prolapse, and then she defecates. And in procedentia, there might be some bleeding, because ulcer is formed, which is called as decubitus ulcer, because of the exposed prolapsed uterus. And ultimately what happens, that daily activities of the life, activities of the patient, they are affected. Now, how do we examine? The abdominal examination is that first we have to go for general examination, the abdominal examination, to exclude any mass or any organomegaly. And then we have to go for the examination in dorsal position. That is, then ask the patient to bear down and strain her cuff, that either there is stress incontinence or not. Then we have to inspect the introitus, and we have to see either it's second or third degree prolapse. And also if there is stress incontinence, we have to perform the urodynamic studies as well in the patient, and to rule out the cause of the prolapse. Now, then in Sims position, that is, patient is put in the left lateral position, and one leg is flexed and other leg is straightened, and then we put the speculum in Sims speculum inside the posterior vaginal wall, and then we do the full inspection of uterine prolapse and the vaginal walls, and the blade of the Sims speculum is inserted along the posterior wall of the vagina. Now, what do we do is that once it is at the peak of the inserted inside the posterior vaginal wall, we ask the patient to scuff. If there is bulge, it is known as interocele. And if we, while taking out the speculum, there is bulge, then it is rectocele. So we have to slowly withdraw the speculum and see any bulge, either it is at the upper part of the speculum or it is seen while withdrawing the speculum. So in this way we can easily demarcate that whether it is interocele or it is rectocele. So we have to differentiate between these two. And ultimately, meanwhile, we have to ask the patient to slowly cuff so that we can easily appreciate the bulge. And we have to assess the uterus and the adnexa, because to see the size of the uterus, and we have to assess the descent of cervix or the prolapse of vaginal walls. They are noted. And also the POPQ quantification system is the system which is nowadays being used in a standard method, in which there is no more ambiguity is there. And it describes 4 stages of the pelvic organ prolapse, which is relative to the hymenal ring, and it is worldwide now being used, and it has now taken over at over all the other quantification methods. And the treatment is either it can be conservative, it can be surgical, depending upon the presentation of the patient and needs of the patient and requirements of the patient, and also the suitability for the anesthesia and any comorbids present in the patient. The comorbids can be any chronic diseases. The conservative measures include the pastries. Pastry can be inserted in the patient who is in the childbearing age, who does not want hysterectomy, who wants local hysterectomy, or she is not fit for surgery, and it is actually inserted between the posterior fornix and symphysis pubis, replaced 6 monthly, and after being washed. And it is mostly a silicone pastry which is inserted inside the vagina after according to the size, and we have to teach the patient how to use it. And also we have to go for the pelvic strengthening. We advise the Kegel exercises, in which the patient has to build up the muscle tone of the pelvis. And also electrical stimulation of the pelvic floor muscles can also be done by physiotherapist. And so these are all the conservative measures. And as far as the surgical procedures are concerned, they are all according to the depending upon the fitness, upon the requirements of the sexual activity or surgeon preference. So either if there is anterior vaginal wall prolapse, there can be colporrhaphy, and that is we remove the redundant or excess vaginal skin, and we repair the facial defects in the anterior vaginal wall. Similarly, in case of posterior colpoperineorrhaphy, when there is posterior wall prolapse, then what do we do is that there is repair of the rectovaginal defect, and there is approximation of the levator ani muscles medially to support the rectum, and in this is called as posterior colpoperineorrhaphy. And in this case, actually the expertise are required, because we have to remove the redundant vaginal skin and give support to the fascia, and ultimately removing the vaginal skin. And vaginal hysterectomy is in case of significant uterine descent, or the patient she is menopausal, or if she is having significant menstrual problems. Now there can if there can be we can also perform the Manchester repair. What is Manchester repair? Actually, it is the procedure preferably done in case of hypertrophied or elongated cervix, and to preserve the fertility, to preserve the uterus, where we do the anterior posterior colpoperineorrhaphy with partial amputation of the cervix. So ultimately, then we go for the approximation of transverse cervical ligaments in the midline to support. And it is preferable in case when there is elongated cervix. Now, sacrohysteropexy is the best method to preserve the uterus, where we actually go by the abdominal route, and we place a synthetic mesh between the cervix and the rectum, and cervix and the sacrum, and this in turn leads to we have to uplift the uterus to align to up to the way that we need the uterus to be supported. And then sacrocolpopexy is that when there is vault prolapse, then it's also by means of mesh. And sacrospinous fixation is actually the vaginal procedure for the vaginal vault prolapse. And the side effect is that there can be narrowing of the vagina, so ultimately it can lead to dyspareunia. Birch corpus suspension is actually a simple procedure which is done in case of incontinence. These were the simple procedures to be taught to remember about the prolapse.